Hello everyone, Ram Reddy here from the Division of Emergency Medicine at Western University. We would like to welcome you to this installment of our Practical Point of Care Ultrasound series, with the focus of this module being the bedside cardiac ultrasound, limited to detection of pericardial effusion and cardiac standstill. As in previous modules, we will concentrate on the practical aspects of generating a good cardiac study, with many more screencasts on various topics being available from our selection at www.westernsono.ca. The goal of our bedside cardiac ultrasound is to generate a view of the heart in the coronal plane, utilizing a subxiphoid view. This is done in order to identify the presence of a pericardial effusion and to determine if the heart has any contractile activity. In more advanced modules, you will learn to generate additional views of the heart in different planes. You will also learn to evaluate and grade contractile activity. However, for this module, we will restrict your focus to two fundamental questions. Number one, does this patient have a pericardial effusion? And number two, does this patient have a heart which is beating? Let's move on to the pertinent orientations for this study. All of our patients are in the supine position, as in this picture here. Our aim is to generate a coronal view of the heart using a subxiphoid view or approach. Now, the most difficult part you learners have with this particular view is understanding the spatial orientation of the probe beam in relation to the anatomic structures and how that image is displayed on the ultrasound screen. Let's try to understand that spatial orientation by using stylized diagrams provided by Sonosite. In this diagram, you can see the probe here. It emits a beam, which is here. You can see that the plane of the beam intersects the liver first, then the heart. How is this displayed on your ultrasound screen? Well, if you rotate this image so that the ultrasound beam is at the top, you will begin to understand the orientation that you see on your screen. Let's show this orientation in a very simple cartoon diagram. The near field structures are at the top of the ultrasound screen. The first structure encountered by the ultrasound beam is the liver, then the inferior portion of the pericardium, and the inferior aspect of the heart, specifically the right ventricle. These structures are considered near field and represent structures that are closest to your ultrasound beam. They are displayed at the top of your screen. Now let's see an anatomically appropriate drawing of the heart in the orientation you will see on your ultrasound generated image. The inferior portion of the pericardium is here. The right ventricle is here. The left ventricle, the right atrium, and the left atrium are also visible on this diagram. Here is the ultrasound image that we want to generate. Again, let's go over the relevant anatomy on the sonographic image. Remember, this is near field, and this is far field. The near field structures are closest to your probe and will appear at the top of the screen. Here is liver tissue. This bright white echogenic line is the inferior pericardium. Here is the right ventricle. Here is the intraventricular septum. And here is the left ventricle. Now let's see the anatomic diagram right next to the ultrasound diagram that should be generated. Again, here is the liver tissue. Here is the inferior pericardium. Here is the right ventricle. Here is the intraventricular septum. Please feel free to stop the tutorial here if you want to let these orientations sink in. So let's move on to the actual technique in performing a sonographic cardiac exam. First, let's get our machine ready by selecting our probe on the triple connect system of the Sonosite. Please note that as you begin your training, you may find that the curvilinear probe is easier to use. The curvilinear probe is actually marked abdominal on the triple connect system. Here's a picture of the curvilinear probe. Note that it has a relatively large footprint. If we tilt the probe like so, the probe marker is now more visible. The probe marker corresponds to the ultrasound screen marker, which is usually a green dot on the left of the screen. On the right is a picture of the cardiac probe. Notice its smaller footprint in relation to the curvilinear probe. For the present time, we suggest you start with the curvilinear probe as it may be easier for you to handle initially. Once the curvilinear probe is selected, please set its initial depth to maximum. You can do that by pressing the depth button. You want to increase the initial depth to maximum, about 20 centimeters. We want to see the whole structure on the screen initially, and then we can decrease the depth to achieve greater magnification. The probe is oriented so that the marker shown here is on the right of the patient's body. This will become clearer as we show you examples of scanning technique. Well, how do we begin? In all our tutorials, a recurring theme will be the approach to the basic application. What do we mean by that? Well, for every basic application, we start first by identifying the anatomic landmark. Then we identify the sonographic landmark, and finally we identify the area of interest. Okay, let's start by identifying the anatomic landmark. The anatomic landmark for this type of scan is the umbilicus. Yes, the umbilicus. This is the landmark you use to know where to place your probe initially. Let's see an example of this. In this clip, you can see that the ultrasonographer is pointing out the ultrasound marker on the probe. When she places the ultrasound probe on the patient, this marker will face the patient's right side, over here. The ultrasonographer will first place their hand on the umbilicus and then place the probe with the probe marker facing the patient's right directly above their finger. Let's watch them as they do this. As the probe approaches the xiphoid, the ultrasonographer looks at the ultrasound screen and tries to identify the sonographic landmark. The sonographic landmark is important as it is the identifiable structure that allows you to orient yourself to the relevant anatomy on the screen. And for all introductory applications, no image interpretation should begin until you identify the sonographic landmark. In this particular study, the sonographic landmark is the heart. And as mentioned previously, it should appear as the probe slides toward the xiphoid. The heart will appear as a black structure mostly, surrounded by a white envelope. It may be moving or it may not be. Once you identify the sonographic landmark, which in this case is the heart, you can begin to look for your area of interest. The area of interest is actually the inferior pericardium and is shown here as the thick echogenic line opposed to the heart. Once you identify this, you are in business and you can begin completing the study. Identifying the area of interest is the first step, but there is still work to do. You must actually sweep your probe through the heart. This is done by slowly flattening the probe until it is almost flat against the abdomen, then slowly coming back and increasing the angle of the probe relative to the abdomen until it is progressively more obtuse. Here is an example of a sweep. Again, the ultrasonographer points out the anatomic landmark and places the probe just superior to that, which is the umbilicus. As she makes her way to the xiphoid, she now completes a sweep, and you can see her hand tilting and tilting back. What is the purpose of this sweep? Well, hopefully this animation will help you understand why we sweep. Here is the heart placed in the supine position. Small amounts of pericardial fluid can accumulate in this area posteriorly. Now, let's say we have an ultrasound probe about here. We can see that the plane of its beam here will actually not intersect where that effusion is. Now, if the probe is tilted like so, you can see that the plane of the beam actually will intersect that pericardial effusion. Doing a complete sweep ensures that you don't miss this type of effusion. Once you have identified the area of interest and you have ensured that you have done a complete sweep, now you can attempt to answer the two questions. Is there pericardial effusion, and is the heart beating? A pericardial effusion will appear as an extra black area between the thick white pericardium and the ventricular walls of the heart. Let's look at a few examples of positive studies. In the first study, shown here, which is a screen capture, you can see the area of interest, which is the inferior pericardium. We can also see the heart. Now notice the black area between the pericardium and the heart. This is an anechoic area and represents fluid. This patient has a pericardial effusion. Now, whether this patient has tamponade physiology is a clinical decision. The ultrasound image in isolation cannot make that determination. Let's move on to an actual real-time ultrasound study. Here we can see the bright line of the pericardium. We can see the beating heart. And you can also see this small anechoic area, which is black, a black stripe, between the heart and the pericardium. This is a pericardial effusion. Here is another study. Please take note of the thick white pericardium, the beating heart, and the anechoic stripe between the two, which is a pericardial effusion. The term we use for a heart that is not beating is cardiac standstill. Let's look at an example of that. Here you can see the heart, which clearly has no movement. This has prognostic significance as the image in the cardiac arrest scenario indicates a dismal prognosis. Remember, the objective of our exam is essentially binary, beating or not beating. We are not interested in gradations of LV function or regional wall motion. These evaluations require more advanced training and will be covered in future modules. Well, we've reached the end of this module. Let's recap. The goal of basic point-of-care cardiac ultrasound is to generate views of the pericardium and the heart in order to answer two fundamental questions. Is there a pericardial effusion, and is there cardiac standstill? We do this by following the basic tenets of introductory ultrasound, which are to identify the anatomic landmark, the sonographic landmark, and the area of interest. Remember, the anatomic landmark in this type of cardiac study is the umbilicus. The sonographic landmark is the heart, and the area of interest is the pericardium. Enjoyed this module and found it to be informative and clear, please visit westernsono.ca for more educational material. Take care and see you soon.